do the first 30 MCQs, and then Damir will continue with the next 30 MCQs. He'll start around like 8:30. Okay, okay. So I'll start. Yeah. Okay. So first thing is like you would have done the paper. I hope. So from this thing you can see the areas of the question that you've asked. So the next paper would be a final assessment paper. So we'll have like 60 MCQs for FAP1 and 60 MCQs for FAP2. So that would be a bit different. So we have enough number of questions to put. So next time won't be like this question paper, because that will like the exam quality questions. So okay. So I'll start with the questions. I won't be going deep into all the MCQs. The MCQs that I think that need more explanation. So the first one is about aortic dissection. So this is purely from the theory itself. One question might be a bit doubtful. So here dissecting hematoma starts between dissection, dissection, right? So it's basically between the medial layers. So there are three layers of intima, media, and adventitia. So between the layers of media, there is blood leaking through an injury in endothelium, and like it's splitting the layers of the media. So either there can be blood leakage into the hematoma in between the layers of media, or else between media and adventitia. So the A is false. B is anterior chest pain radiating to the back between scapula. That's a characteristic symptom. So that's true. Can cause myocardial infarction. Yes. What happens is there is blood collection outside the vessels, but not in the extravascular compartment. So blood is basically going between the layers of the media and compressing on the blood vessels. So if that compression also happens in the coronary arteries, like around the heart, there can be myocardial infarction because there's less blood supply to the heart. So that's true. Cardiac tamponade and due to rupture pericardial phase, possible moderate. True. Tamponade means there is some fluid in the pericardial cavity of the heart. So the pericardial cavity of the heart, there is fluids. Here there is blood. So blood collects in that pericardium because there is the blood from these dissection leaks into that thing, and it compresses the heart. Because of that, there will be the heart will be trying to pump blood out of the heart, but there is a restriction here. So it cannot expand to its fullest. So the cardiac output decreases. So there can be heart failure and can die. DBAK stand for the classifications are not useful. That is false. That is those. There are two classifications which you use. Those are those two classifications which you might that's needed. And then about myocardial infarction, you need to know the complications as well as at each day what is the changes that happens in the microscopic changes that happen in the cardiac myocardium. So you need to know those things. So those are the charts and as well in the lectures. So go through that as well. So here I put all the complications, like there can be arrhythmia, which is the killer in myocardial infarction. So the heart attack doesn't kill you, but the arrhythmia is the one that actually kills you. So most of the people in the first hour is the most dangerous. That's because of arrhythmia. And left ventricular failure is a huge infarct, like 40% or something. There'll be immediate left ventricular failure and they can die. And then cardiogenic shock, pulmonary muscle dysfunction, myocardial rupture. That's also important. You need to know when this happens, because arrhythmia happens then and there. Myocardial rupture, that means like ventricular wall rupture, happens between 3 to 7 days. So you need to monitor the patients after the heart attack. You can't just let them go home immediately. So myocardial rupture can happen. Acute pericarditis, nearly the same range, 2 to 4 days. Chronic pericarditis in 2 to 6 weeks. So you need to know the time duration for those things. So here they say first one is true. VSC, like ventricular wall rupture, happens like 3 to 7 days or something. Arrhythmia, sudden death, true. Chronic pericarditis, 1 week, false. 2 to 6 weeks. Acute pericarditis never gets resolved, false. It normally gets resolved. It's not a huge issue, acute pericarditis. Left mural thrombi can embolize this limb ischemia, yeah. Because there is, a part of the heart muscle is not properly working, so there can be blood stasis. So that can cause thrombi. So that thrombi can get embolized. This is from the left side of the heart, no? So from the left side of the heart, it goes to systemic circulation. So if it goes to the vessels of the lower limb, there can be, or lower limb, upper limb, there can be ischemia of that limb. So that is true. About rheumatic fever, so you know about rheumatic fever, right? So it's basically a antibody mediated kind of inflammatory disease because of a post streptococcal effect. Like it's the basically it's autoimmune against our antigens because of that prior infection. So rheumatic vegetation form emboli do not. There will be vegetation, but they are very small. They are not fried endothelium. So the valve, from the valve edges, they don't get removed because they are very adherent to it. They are very small and they are because of microthrombi, not because of any kind of infections. So it is a very aseptic vegetation. So that is false. P is commonly mitral valve. That is true theory because there is lots of high pressure areas in the left side. No, so if there's high pressure, there can be high turbulence. So that part of the heart will be affected more. And these affected valves are more affected because of due to the rheumatic fever, the antibodies that act against it. Ashoff bodies, subendocarditis characteristically, that's true. There are Ashoff bodies which are kind of like a granuloma. Oligoendocarditis false. It causes pancarditis. So although there is no rheumatic heart disease or rheumatic fever, it affects all three parts of the heart, like endocardium, myocardium, and pericardium. Acute rheumatic fever causes buttonhole stenosis. That's false. Buttonhole stenosis happens when there is fibrosis of the mitral valve, causing constriction of that area, causing narrowing. So there will be stenosis of the mitral valve. That's known as buttonhole stenosis because it looks like a buttonhole. So the permanent fibrosis and valvular changes happen chronically. So if multiple times you get acute rheumatic fever, that goes into chronic rheumatic fever, chronic rheumatic heart disease. So that is the time when you get the buttonhole stenosis, not an acute thing. In acute thing, it will be like different. It will be like edema of the valves. That can be like uh, mitral stenosis or regurgitation. That's mainly because of edema and acute changes. And That can be like I told you, there'll be three things like endocarditis, myocarditis, pericarditis. So those three things can happen. That's acute. Chronically, mainly it would be a valve changes. And then question 4 regarding vasculitis, polyarteritis nodosa affects pulmonary arteries. That's false. That's a mnemonic you can remember. That's plan B. Plan B. So here's polyarteritis nodosa that does not affect pulmonary arteries. So remember like that. And the B here stands for this polyarteritis nodosa can occur after hepatitis B infection. So that's a plan B. So remember like that. So it affects mainly renal, dermal, visceral arteries, not pulmonary arteries. This is a very important point to know. Kawasaki valvular conjunctivitis, like aseptic thing, no, there is no infection here. It's an autoimmune disease, autoimmune vasculitis. So that is what's happening here. And Yeah, so that is false. Microscopic polyangelitis causes glomerulonephritis. That is true. Like in the there are here put it. So there are in the small vessel diseases, small vessel vasculitis. There will be microscopic polyangiitis, granulomatosis, which is granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis, which is Church-Strauss syndrome. So those things are there. No? So among them, these two, microscopic polyangiitis and granulomatosis polyangiitis, these two causes glomerulonephritis. Church-Strauss is more like a, how do you say, allergic kind of thing. So that's why you get asthma kind of things, but not the other things. So it's like asthma, eosinophilic pneumonia, those things will be there. Here, in these two things, you get pulmonary hemorrhages and glomerulonephritis. In addition, there will be like cavitation, whatever, like nearly the same thing between and nasal septum perforation. Like this is like lower respiratory tract and urinary tract. Here, in addition, there will be a upper respiratory tract issue. That's the nasal septal perforation in Wegener syndrome. Yeah. Yeah. So that is one. And chronic sinusitis. That is true. Sinusitis is like here is there. No? It's like upper respiratory, lower respiratory, and kidney issue. So that's how you remember it. Church-Ross causes cardiomyopathy. I don't know. They asked that question. Even I didn't know this earlier. It seems it does cause myocarditis. It's good to know, I guess, even if you don't remember it. I don't think they'll ask. Mainly, they'll ask about asthma and eosinophilic pneumonia. So that's true. Yeah. So next one is about pulmonary edema. Pulmonary edema happens because of various reasons. So there can be increased hydrostatic pressure, decrease oncotic pressure. So you know about edema, right? So those things, lymphatic obstruction, direct injury causing, those are like exudate. These are transudate forming things, exudate forming things because of injury, inflammation, and those kind of stuff. So those are reasons for pulmonary edema. SIRS can cause pulmonary edema due to alveolar orange. That is true. SIRS is severe. It's an inflammatory reaction. So that's the SIRS thing. Okay. So it's known as a systematic inflammatory response syndrome. So it's kind of like sepsis without infection. So sepsis without infection is known as SIRS. They don't usually ask that thing, but it's an inflammation. So it causes alveolar wall injury. That's true. Fluid accumulates first in apical regions and heart failure falls. That's why you get in the basal region. So that's why you get basal crepitations in heart failure. Okay. So you need to know that. It's a very common thing. Increases the risk of pulmonary. That's true. If there's fluid in the lungs, there can be infections. Long-standing pulmonary edema causes fibrosis. Anything that happens for a long time causes chronic inflammation. So that will result in fibrosis. That's common. Pulmonary edema can indicate lung carcinoma. That's not an indication. Like lung carcinoma, there are so many other things. So you don't go for lung cancer just because there's edema. So here are some causes of edema. Just go through them. I'll upload the PDF. Pulmonary arterial hypertension. So it's kind of like it's also like hypertension. So you don't have to especially study these things. Like general thing. Hypercapnic acidosis, pulmonary causes hypertension. That's true because in the lungs, if there is excess carbohydrate, the carbon dioxide in one area, there will be vasoconstriction. If there is excess oxygen, there will be vasodilation. It is the opposite in the systemic circulation because when organs have lots of CO2, there should be more blood flow to that area. So there will be more vasodilation because of carbon dioxide in the systemic circulation. But in the lungs, there should be more blood flow to area where there is more oxygen. So that there can be more oxygen going into the blood. So there will be vasodilation in oxygen. So here, that's true. Pulmonary arterial hypertension can be heritable, that can be possible. Heart failure, preserved ejection fraction, known cause of pulmonary hypertension. We know that, no? So if the left side of the heart is failing, then there will be increased pressure in the left side, which can cause back pressure into the lungs, causing hypertension in the lungs. Tunia medica is only affected. No, all three layers of the lung, the vessels of the lungs will be affected. Chest pain is a recognized feature. That is true because it's in that area, no? So there can be several reasons. One can be restricted blood flow to the heart as well, and there can be sensory neurons around the vessel. So there is like stretching of the vessel. There can be pain. Those things are there. Adenoma polyp, which can cause indicate increased risk of malignancy. So for increased risk of malignancy, these are the things. The size matters in polyps, not in all polyps, but in the lower GI polyp, size is an important indicator. So if the size is larger, more likely to be a malignant thing. And the type of the epithelium, if it is more villous, because in the lower GI, in the colon, there is a tubular epithelium. No, there will be like simple columnar epithelium with tubular structures. No, so that is a normal thing. So if it is a tubular, it has less risk. If it's villous means there will be villi. Villi will be where in the small intestine. So that's abnormal, very abnormal in the lower GI. So that can indicate high malignancy. Multiplicity. That means like there are multiple polyps. So that be like a syndrome. No? So that is high risk. And then the presence of dysplasia. Yeah. So in presence of dysplasia, that's automatically that is true. So hyperplastic feature, that is no, that's not a feature. That is a benign polyp actually. So that's false. Multiplicity true. High grade dysplasia true. Size over 2 centimeters true. Tubular false. It will be less. So about esophageal diseases, squamous cell carcinoma more common in the lower third. That is false because squamous carcinoma occurs mostly in the middle one third because of smoking, alcohol, achalasia cardia, Plummer-Vinson syndrome, those kind of things. Because there is stratified squamous epithelium in the normal esophagus. So anything that can irritate the thing and cause it. But in the lower third, mostly it will be an adenocarcinoma of the esophagus because about the Barrett's esophagus. No? When there is reflux of acid from the stomach, it irritates the lower esophagus first. So that causes metaplasia. There will be intestinal type metaplasia of the lower part of the esophagus. So that turns into like intestine like endothelium. So epithelium. So what is the type of epithelium that is in the intestine? There'll be like secretory thing. So there'll be like glands. So that kind of thing causes cancer called adenocarcinoma because there'll be more glandular type of carcinoma there. So that's false. False. So tumors of the candidate aspiration pneumonia is also no can spread. That can spread from the esophagus into the trachea as well. So that is true. Or else that can be, it can block the food from going into the esophagus. So that can go back and go into the trachea as well. So that's true. Diabetic recognized cause of achalasia. That is true. Achalasia basically means the normal function of the esophagus is lost. So there is no normal peristaltic movements of the esophagus, the motility disorder. So in diabetic neuropathy, what happens? The nerves are not properly working. So that means the esophagus will also not properly do peristalsis. Trachealization of esophagus, you see it in eosinophilic esophagus. That is true. That's theory. Just go through it. Presence of goblet cells are diagnosed by that is true. Barrett's esophagus means more a secretory thing. No? So that means goblet cells are a diagnostic feature. Goblet cells are found in intestines. So that is not normally found in the normal esophagus. But in Barrett's esophagus, there is an intestinal type metaplasia. So that means there will be goblet cells there as well. Regarding diverticulosis, common site occurs the transverse colon, no false. It is the sigmoid colon. Diverticulosis is basically what happens is there are certain areas in the colon that are weaker due to arteries coming from outside to the inside. So that area is weaker. So when there is that, there will be outpouchings of the mucosa and submucosa through that weak areas of the colon, causing bulging out of the colon through those small areas. So that is diverticulosis. So feces can get stuck in there, causing infections. So that will become diverticulitis. Okay. So true diverticular in mostly left colon, that is false. They are false diverticular. True diverticular means basically all layers of a structure are going through a certain opening or certain structure. Another certain abnormal going through basically. Here it's false diverticular because only the mucosa and submucosa are pouching out, not the muscularis propria or the serosa. Okay. Abscess formation is complicated. Yeah, abscess because there's inflammation, no? So perforation because the weak area can rupture. Then there'll be hemorrhage, obstruction because pieces can get stuck in there, preventing the flow of the fecal matter. So that's true. Can present alternative constipation diarrhea. That's also true because there's inflammation as well as blockage. Regarding histology of the glomerulonephritis and microscopic appearance, this thing is pure theory. So just go through it. You need to go through the single lecture. It's very important. Must. Acute diffuse proliferative glomerulonephritis. That basically is like in post-streptococcal glomerulonephritis, this kind of picture is found. So there is neutrophilic infiltration. That's true because there is inflammation going on, and there will be granular subendothelial deposits as well. Yeah, and membranoproliferative nephropathy, double contour, that is true because there is membrane proliferation. So in silver staining of the glomeruli, you'll get double layer. So it's also known as tram track appearance of the glomeruli. FSGS, focal segmental sclerosis, means in certain areas, like less than 50% of the area of the glomeruli get sclerosed, get thickened. So that is FSGS. So IgG deposition along the capillary endothelium, that is false. There is a segmental sclerosis. Only small parts of the whole kidney will be affected, and only even in the same glomeruli, only less than 50% or something will also get sclerosed, not the whole glomerulus. So IgG deposition along the capillary endothelium, that happens in anti-glomerular basement membrane disease, anti-GBM disease, also known as what's syndrome? So it's basically it happens in a type of rapid crescentic glomerulonephritis. Yeah. Membranous nephropathy happen mesangial proliferation. That's false. The name itself is false. It's spike and dome appearance, and glomerular based membrane thickening happens there. Minimal change disease. It's in the name itself. You won't get any light microscopic changes, but in the electron microscope, you can find there will be fusion of the podocyte. There will be retraction of the podocyte. Normally, podocyte should be the processes of the podocyte should be on the basement membrane. Here, there is retraction of those things, those parts of the podocyte. So that's true. 65-year-old male, long-standing diabetes, developed nephrotic syndrome. Renal biopsy done and show reveals diabetic nephropathy. What are the findings? So this is kind of an important thing. So this is you can find in the diabetes lecture, the changes, pathological changes in diabetes. That's a very important lecture. You must know each and every point in it, basically. Glomerular crescents, false. Glomerular crescents happens when there is acutely very severe damage and inflammation to the glomeruli. Here, diabetes is a very slow thing, so you don't get glomerular crescents there. High in arterial sclerosis happen differently. That's true. That also happens in arterial when there's like hypertension. Also that happens, but in diabetes also there is basically blood flow to the kidneys decrease. There'll be hypertension in the body, and there'll be arterial sclerosis. That's normal. That happens. So the renal vascular changes, you get highly in arterial sclerosis and renal atherosclerosis. There will be glomerular changes, vascular changes, and infections. So interstitial fibrosis that can happen in a chronically diseased kidney. So that's why they go into CKD and all. Nodular glomerulosclerosis, that's the Kimmel-Wilson nodules lesions that happen in nodular glomerulosclerosis. That's a characteristic finding. Tubular atrophy also happens in those kind of kidney because chronically there will be decreased blood supply to the kidney, causing atrophy of the tubules. Okay. And regarding renal cell carcinoma, clear cell, there are like 4 types of carcinoma, I think, like chromophobe carcinoma, clear cell carcinoma, papillary carcinoma, and collecting duct carcinoma. I remember it like it's renal cell carcinoma, no? RCC. So it's like before R there is P. So there is papillary carcinoma. C is collecting duct, clear cell, and RCCC kind of chromophobe. So you remember like that. Clear cell of homogeneous gross appearance. No, although it's named as clear cell carcinoma, the kidney looks variegated. Okay. So it looks like there is hemorrhage, necrosis, and so many other things, different colors. Has tendency to grow in the renal vein. That is a common finding in renal cell carcinoma. The tumor can go into the renal vein. Sarcomatoid differentiation, good prognosis, false. Rhabdoid one kind of shows good prognosis. Sarcomatoid means kind of like a sarcoma. So the name itself is so cancer, no? So it cannot be a good one. Associated one Hippel Lindau syndrome. There are a few familial syndromes that can cause renal carcinoma. The one Hippel Lindau, hereditary leiomyomatosis, hereditary papillary carcinoma. So the other names they might ask in MCQs, but unlikely to be asked in an MCQ. But at least know one Hippel Lindau syndrome. Polycythemia is known manifestation, yes, because of the paraneoplastic syndrome. So that I remember is like pyrroneoplastic syndrome. So PPTH related protein, E erythropoietin, AACTH, and R renin. So these hormones are released as a paraneoplastic syndrome. So you also, if you know the hormone, you know the effect. No, so erythropoietin causes polycythemia, renin causes hypertension, hypertension and renin, you know what renin, no? ACTH, Cushing's, PDHRP causes parathyroidoma. No, what does it do? It increases the calcium in the blood, so it causes hypercalcemia. So likewise, you can remember. Myelodysplastic syndrome. It's a simple lecture. You can go through it. So basically, there is abnormal cells forming in the abnormal formation of hematopoietic cells in the bone marrow. So it happens in elderly. Character dysplasia. So the name itself is dysplasia as well. So there'll be like nuclear atypia, cell atypia, the nucleus to cytoplasm ratio will be different, and those things are there. Okay, and increased degree of hepatosis seen in the bone marrow. That's true. There is increased dysplasia, also there are abnormal cells. So there'll be increased production of cells as well as increased destruction of the cells. No? So that's why it's like that. And abnormal clones is stable, obviously no. That's why it's dysplastic. Blast percentage or in blood marrow more than 20%, no longer MDS. In any kind of leukemia, lymphoma, whatever, if the blood bone marrow, the blast percentage is more than 20% in the blood, then it goes into a condition known as lymphoblastic or myeloblastic leukemia, acute myeloblastic or acute lymphoblastic leukemia. So that's a very acute situation. So there can cause several issues as well down the line. That's a thing you need to know. Okay. And so that is true. DIC, it's like disseminated intravascular coagulation. So it's not a primary disease, meaning there will be definitely some other cause, some other secondary cause for this kind of finding. So it's not like a primary thing. So it's a reaction to a secondary thing, but it's a very dangerous situation. So there will be, there will be coagulation as well as blood being going out of the body as well. So everything happens at the same time. Yeah. Okay. So the next one. So D dimers is elevated. Yes, because there will be coagulation. So there is coagulation inside the vessels. So there will be D dimers. So that's true. Target cells are seen. False. Here there will be schistocytes, meaning bite cells. Yeah, schistocytes. Basically, there is intravascular coagulation. No? So when red blood cells go through that, they get sheared off. They'll get broken. So there'll be cell fragments of red blood cells like this thing. There'll be like one part of the cell is broken, kind of like this. So that is this thing. And target cells are normally found in iron deficiency anemia, thalassemia, those kind of. Heparin is given in treatment. That is true, but only in certain situations because heparin, it's an anticoagulant. So DIC also there's coagulation. We need to prevent it so you can get anticoagulant. But that's not for the acute disease. Acutely, the main thing you need to do is to treat the cause because it can happen due to various things. Okay, multitude of things that can cause this condition. There can be like sepsis, some kind of infection causing it, snake bite, toxins, severe acute pancreatitis, obstetric issues, malignancies, nephrotic syndrome. There are so many other causes for this. So you should treat the cause to prevent this thing, so to stop this thing. If it is very severe, you can also give like RBCs, factor concentrates for like if there's severe bleeding or something like that. Deficiency of fibrinogen is a characteristic in all cases. That's false. Only 53% or something of people who have DIC get deficiency in fibrinogen. But in 98% of people who get DIC get thrombocytopenia. So that's the thing you need to know. Regarding anemia of chronic disease, so chronic disease, there can be anemia due to several things because of erythropoiesis can be inhibited. There will be increased hepcidin, so it reduces the iron from being released. Um, um, and so many other causes can cause decreased uh, red blood cell production. So it is also elevated total iron binding capacity. That's false because there is enough iron in the body. So the iron stores is normal, but the iron being released from that store is abnormal. It's not properly released and utilized. Because of that, you will find high serum ferritin, but serum iron would be low, and there will be reduced total iron binding capacity. You reduce the normal total iron binding capacity because the issue is not with the iron. It's a normocytic normochromic. Yeah, usually. It also can be microcytic hypochromic. Treated with iron supplements, false, because iron is not the issue. Produced by the cytokines, reduces utilization of iron stores in the body. That's true. Associated with the rise in ESR, true, because there's an inflammation going on. Even though it's a chronic inflammation, it's an inflammation. So there'll be increased CRP levels, increased ESR levels. Which of the following favors thalassemia? This is a theory thing. So acanthocytes are found in liver diseases. That's no. Hyperhomocystinemia, that happens because homocysteine is reduced into cysteine. Like homocysteine is a toxic compound. So that is changed into cysteine in the process called one carbon metabolism. You know that folic acid pathway, no? So in which like folic acid forms some other things like tetrahydrofolate, for methylene tetrahydrofolate, N5 and those kind of things, so 4 miles tetrahydrofolate, those things. So there's a cycle. So in that cycle only folate get used and you get several things there. You get pyrimidine synthesis. Yeah. Purine synthesis, you need that cycle. DNA, so for basically for DNA synthesis, you need that cycle. And also for methionine synthesis, you need it. So those things you need. So this happens when there's B12 deficiency, folate deficiency. So that cycle won't happen. Hypersegmented neutrophils, obviously, is in B12 and folate deficiency happens in megaloblastic macrocytic anemia. Target cells, obviously, in iron deficiency thalassemia. Hypochromic cells also, iron deficiency and thalassemia is here. Thyroiditis, basically the inflammation of the thyroid gland. So Hashimoto thyroiditis is more common in males than females. That's false. All types of thyroid issues mostly happen in females. Mostly. So subacute lymphocytic thyroiditis, smooth enlargement of thyroid gland. That is true. That's a painless enlargement. It's associated with pregnancy as well. Subacute granulomatous thyroiditis, most common cause of thyroid pain. So the other types of thyroiditis usually don't cause pain. So Hashimoto, subacute lymphocytic thyroid, they don't cause pain. But the thyroid that causes pain is the subacute granulomatosis. It comes and after a few weeks, it goes away. So it's not a chronic thing. So that's true. Follicular carcinoma can occur following chronic multinodular goiter. Yes. In a multinodular goiter, there will be hot nodules. There can be like multiple times. There will be enlargement of the thyroid gland, contraction, enlargement, contraction, blah blah blah. It happens, and there will be certain nodules forming in the thyroid gland. If there are mutations in those nodules, then they will produce increased amounts of thyroxine. And then there can be mutations happening again and again. So those nodules will turn into a cancer. That will be a follicular carcinoma. You should know it's a precursor. It's not a precursor, it's a risk factor, basically. Hashimoto thyroiditis present as a single nodule. No, usually Hashimoto's is it's an autoimmune disease. No, so the whole gland will be affected. So it won't be a single nodule that causes this thing. So there'll be a diffuse enlargement, diffuse goiter, that will present in Hashimoto as well as Graves' disease. Regarding these endocrine glands, parathyroidoma causes primary hyperparathyroidism. That is true. Parathyroid is one that releases parathyroid hormone. No? So if there's adenoma, then there'll be hormone release there. Long-term steroids can result in adrenal cortical atrophy. That is true because you are giving steroid to the body. Normally, the normal natural steroid, the natural corticosteroids, are produced in our adrenal gland. So if you artificially give those things, there is no need for the body to create corticosteroid. So what happens is that our body naturally produces less amounts of ACTH, and that will cause shrinking of the adrenal cortex. So that's that adrenal cortex atrophy. It suppresses that thing. So if you suddenly stop steroid without tailing it off, then suddenly our body will not be producing our normal amounts of corticosteroids as well. So that's why you never suddenly stop steroids. Tuberculosis is if you have been using for more than 3 weeks, I think. Tuberculosis is a cause of adhesive. That's a common thing you should know. It causes granuloma in our adrenal gland, so can cause adhesive disease. Basically, there's reduced production. Uh, I hope you guys can hear me. And the call came in. Uh, yeah. So yeah, and the next one is medullary carcinoma. That thing. Thyroid associated multiple endocrine neoplasia. Men two. Yeah. So medullary carcinoma. You should know uh, the cancers that are associated with each carcinoma. Okay, so here I put a picture. You should know this thing. So men1 is 3P, men2 is 2P1M, men2B is P2M. So you should remember like this mnemonic and these things, they can be asked in MCQs as well. Okay. Okay, and 19.1 regarding pathological features and complications of diabetes. So those things is in the you should know in and out about diabetes. So this thing I'm going to discuss reposition pancreatic islet is commonly seen in type 2 diabetes. That is true. Amyloid, it's like a abnormal kind of, it's a protein leakage out of the vessels because there's like damage endothelium and so many things going on. Wilson disease nodules are characteristic. That is true. Non-enzymatic glycation happens in one, but not in two. That's false. In both types of diabetes, that happens because there's uh, increased amounts of okay. So there is increased amounts of this thing glucose in our body. So I'll put this document in the group as well. So. Okay. So okay. Okay. So that's true. That's false. In both types, you get it. Diabetic patients are increased with atherosclerosis. That's true. That is the exact reason why you get more atherosclerosis in diabetic patients. Autonomic neuropathy in diabetes primarily affects the sensory nerves and rarely affects cardiovascular. That's false. So that's why they are unable to properly control their heart rate. So they might be having like exercise tolerance or whatever because they cannot increase or decrease their heart rate according to their need. as well as if there is like heart attack, they won't, but like people who have diabetic neuropathy may not be able to express it because the nerves are not properly working. So they won't feel the pain. They won't get the normal autonomic symptoms. They'll suddenly faint. Yeah. And acute pyogenic meningitis. Pyogenic meningitis means that it's caused uh, by bacteria. So common pathogen in neonates is false. Obviously, it is Streptococcus galactiae, group B Streptococci, E. coli, and Listeria. So those three are the ones. Can present headache and photophobia. Yeah, in adults it can be. And pneumococcal meningitis, exterior can be in the basal surface. No, in pneumococcal meningitis, it's mostly the convexities of the brain. So in the outer parts of the brain, you get X-ray. But in like hemophilus influenza and TB, you get basal X-rays. Hemorrhagic cerebral infarct, that might be true because there's like inflammation going on. No? So inflammation damage to the endothelium, there can be hemorrhage. Cerebrospinal fluid examination shows high protein and high glucose. False. There will be low glucose. There will be glucose less than 2/3 of the normal glucose found in serum. So you get the serum glucose and the CSF glucose. The CSF glucose would be less than 2/3 of their serum glucose level. So that's a characteristic finding. Which of the following statements are true? Rabies peripheral nerve. That's true. So it goes to peripheral nerve, goes to the spinal cord, then goes to the dorsal root. So the dorsal ganglia proliferates and then goes up into the brain, and then from there it goes to all the glands. It proliferates there, and people die. Yeah. So pulmonary X-ray more suggestive pneumococcal, same thing. It's TB or H influenza. That's false. Hearing loss complication, yeah, it can be. There's pyogenic meningitis, there's inflammation, sparks going in there, compression of the nerves can cause it. Enterovirus, the commonest cause of acute aseptic meningitis. That's true. Aseptic means if you culture that thing, you won't get an organism. So it will be probably a virus. Cranial nerve palsy is a complication of TB. Yeah, that's true. Because there will be like fibrinous or gelatinous kind of X-ray in the base of the brain. So that compresses the nerves, prevents the blood supply to the nerves, damages the nerves, causing cerebral nerve palsy. Berry aneurysm. Berry aneurysm is basically aneurysm that happens in the circle of Willis. In the circle of Willis, it happens. 90% in anterior circle, that's something you need to know. That's true. Probability of rupture decreases with size. False. It increases with size. The more the size, the weaker the wall. So it can easily rupture. Increase with internal pressure. If there's pressure increase, it will rupture. That's true. Associated with neurofibrinosis type 1. That is true. There are certain conditions which are associated with perianeurysms. Here are they. Autosomal dominant polycystic kidney disease, Marfan, neurofibrosis type 1, coarctation of aorta, cigarette smoking, hypertension, and so on. Regarding tumors of the brain and spinal cord, medulloblastoma affects the cerebellum. That is mostly, yeah, that's true. Medulloblastoma is a tumor it's a malignant tumor of children, the brain tumor of children, mostly intraterritorial. So that is on this cerebellum. There are certain things you need to know. So you need to know about meningioma, this thing, and there are some other types of tumors that you need to know, like glioblastoma, astrocytoma, commonly asked. Extraneural metastasis is common, that's false. It's very rare in primary CNS tumors. Neurolemoma can present with tinnitus if it arises in the CP angle. That is true. Neurolemoma is basically it's a tumor of the Schwann cells, the nerve sheath. So the outside the cell, you have the Schwann cells and nerve sheath. No? So there is a tumor there. So if it happens in, let's say, the nerves, the cranial nerves that are going through that CP angle, there can be a tinnitus because it affects the CP angle has the vestibulocochlear. So if it is compressed, they'll get tinnitus. Glioblastoma tumors common in all adults, that is true. Oligodendroglioma shows fried egg appearance under microscope, that is true. There are also other certain findings which you need to know. chicken biovasculature, and calcification. Just remember it. Cervical carcinoma, cervicectomy is performed only for symptomatic. False. 35 and above, you do the as a screening test. Even if you don't have any issues, you do go and do the test. Thin pap smear more accurate. That is true because it causes it reduces the the issue that come due to drying of the pap smear, normal conventional pap smear. Reported according to Bethesda, that is true. It's theory. HPV DNA testing screening method of choice because more sensitive. That is true. In Sri Lanka, it is not done, but it is the choice according to choice of screening according to WHO. So you need to know that it's true. So if they ask for screening of choice, it's actually HPV DNA test. Low-grade squamous intraepithelial lesion have 25% of regression. That's false. Most of the squamous intraepithelial lesions can regress. Okay, it's only a very few percent that goes into actual cancer. So low HCl, it goes in HCl is lower. So it's like 60 to 70% regress actually. Regarding endometrial diseases, meaning like diseases of the endometrium of the uterus. Retained products of conception cause acute endometrial. That is true. If there are contents of conception inside the uterus, if it's not expelled out, then there can be infection of those things causing acute endometritis. That's true. Tuberculosis is recognized cause of chronic endometritis. That can be possible. It's a chronic inflammation now. Endometrial polyp typically cause intermenstrual bleeding. That is true. So because from the polyp, whenever it gets like agitated or whatever, it bleeds. So it won't be like a cyclic bleed, but even between menstrual cycles, it can be bleeding. Tamoxifen increases occurrence of endometrial polyps. That is true. Tamoxifen is it's a competitive antagonist for estrogen. So it binds the estrogen receptors in the endometrium. So although it prevents estrogen activity, it is not the inverse agonist. So it's kind of like a partial agonist. So it works as a partial agonist. So its activity is lower than the oxytocin, but still it has estrogen, but it has estrogen activity. So if you give that drug, it can increase polyps because polyps are basically what? They are proliferation of the endometrium. So estrogen causes endometrial thickening. So it does basically the same thing. So it can increase the polyp formation. Obesity leads to endometrial hyperplasia. That is true. Obesity means there is increased fat. But estrogen is produced from fat. It's produced from cholesterol. So if the people are obese, there will be more fat. So it can increase the peripheral conversion of androgen to estrone. So that's true. Regarding breast diseases, double assessment for it's triple assessment. So you do a clinical and radiological, as well as a histological assessment. So FNAC more accurate corneal biopsy false. Biopsy is always better. Early tumor present with nipple retraction false is a late sign. Like nipple retraction, pod orange appearance, nipple discharges. Those are very late signs. MRI is indicated in screening high risk women. Yes, in high risk people there can be metastasis as well. So in order to find that thing, we do MRI. Regarding inflammatory breast diseases, acute mastitis mimics inflammatory carcinoma. Acute mastitis is basically inflammation of the breast due to something like streptococcus aureus or something. So there is inflammation. There is also a certain type of carcinoma that can occur in breast. It kind of mimics inflammation. So you should always exclude inflammatory carcinoma if you suspect acute mastitis. Duct ectasia presents the second decade in nullipacimen. Duct ectasia basically happens when there is secretion into the ducts, the breast ducts. Okay, so that is basically the thing. So in fifth and sixth, so normal like young people won't get that much secretion into their ducts, no. So it'll be like older people who had multiple pregnancies who can have this issue. Smoking associated periductal mastitis, that's theory, you need to know. It causes metaplasia of the epithelium. Normally, it is lined by uh, simple cuboid or simple column epithelium, but it gets converted to famous epithelium because of the metaplasia in people who smoke. Periductal mastitis results in dysplasia of ducts. That's true. When I told you. So that's false. It's not dysplasia, it is metaplasia. The cells are normal. They have normal nuclei, but it is the squamous epithelium. That is the issue. Granulomatous lobulomastitis is a differential diagnosis for tuberculosis metastasis. Yeah. In the name itself, it says granulomatous mastitis. So there are granuloma formation there. In tuberculosis also, what do you get? There will be granuloma formation. No, so that is true. You should also suspect something like sarcoidosis, TB, or something like that. If the patient has, the clinical picture will be something like this. Match correctly. Osteomalacia, vitamin D deficiency. That is true. Osteomalacia in adults recurs in children. So vitamin D causes abnormal mineralization of the bones. Okay. So that causes abnormal shapes of maturation and sizes and whatever. Osteoporosis, histological abnormal, false. It's normal bone, but it is thin. It is like very less density. Bone mass will be low because there is decreased bone formation. Osteodystrophy in hypoparathyroidism, that is true. Here, osteodystrophy happens when there is increased resorption of the bone. So that is increased resorption means increased destruction of the bone. So that is found in hypoparathyroidism. Why? Hypoparathyroidism means PTH hormone is increased. What does PTH do? It increases the calcium in the blood. So if you need to have more calcium, what should it do? It takes the calcium from the bones and releases into the blood. So that's why there will be more resorption of the bone, causing dystrophy. It can also happen in CKD. So CKD, there's a thing called renal osteodystrophy. Okay, so that is also there. Rickets, I told you, not calcium deficiency, but vitamin D deficiency. Osteogenesis imperfecta, it is a collagen synthesis defect. That is true. Collagen, type 1 collagen. Regarding ankylosing spondylitis, it is a type of seronegative arthritis. Okay, so seronegative arthritis associated with HLA-B27 allele. So that's theory, need to know. So other seronegative ones are something like psoriatic arthritis, this thing. There is one more, I think. Common in young male and writer syndrome. So those things are there. Common in young males and females, that is true. Can lead to respiratory difficulty, is true. Why? The ankylosing spondylitis happens in the axial skeleton. So there will be ankylosis mean fusion of the bones. So the spinal column will be fused. So initially there will be like fibrous tissue formation and then there will be calcification. So if there is no treatment done, there will be a very stiff spinal column because there is calcification. So the person won't be able to bend forward or bend backward. So there is a curvature of the chest as well, the thorax as well. So because of that, he won't be able to move his spine. So he'll be like a statue. So he has high risk of fracture as well. So respiratory districts happen. Why? Because now the rib cage and the spinal column is very rigid, and the person is like hunching forward. So he won't be able to breathe properly. Extra-articular manifestation not seen, that's false. This is associated with uveitis, aortic problems, something like aortitis, aortic regurgitation, and tendinitis. The CSR is a feature. True, because this is an inflammation of in any inflammation, there will be increased CSR. Bone tumors, primary bone tumors are more common than secondary. False. Always secondary bone tumors are more. Secondary means it's coming from some other primary tumor somewhere else, like breast tumor, breast cancer, endometrial cancer, prostate cancer, something like that. Multiple osteomas associated with Gardner syndrome. That is theory. Yeah, it is true. Paget's disease is a precursor region for osteosarcoma. Yes. Osteosarcoma is also associated with radiation, chronic osteomyelitis, implants, and Paget's disease. Osteoblastoma affects axial cell more than long bones. That is true. It's theory. I put a comparison chart here. Just go through it. I have a by an idea is fine. Identification of osteoid is a prerequisite for diagnosis of conventional osteosarcoma. That's true. In osteosarcoma, the name itself is osteo. So there should be bone formation inside the tumor. So if there is no new bone formation in the tumor, you can't say it as an osteoid. No. So osteosarcoma, you need to have osteoid there. If it's a chondrosarcoma, you need to have chondroblasts, abnormal chondroblasts, chondrocytes in the tumor. That's true. So I've discussed the first 30 questions. The next 30 questions will be discussed with Damaru at 8 p.m. So you can join the meeting at 8 p.m. I guess. You can take a small break now. There won't be an SCQ discussion. So if you have any doubts, you can ask me now. Okay. You can join the meeting at 8 p.m. So thank you for joining. I hope you were able to understand something. I know it's fast, but there's no other way. Thank you.
Okay, Majan. Can you see my screen? Hello, Tua. Majan, can see. Majan, is the screen visible? Yeah, Majan. Ah, okay. So, good evening, guys. Let's continue with the rest of the TMCUs. Question number 31. Uh, which of the following are true regarding antihypertensives? So, this question asking about antihypertensives. So, STEM 1. Nifedipine is indicated in treatment of hypertensive patients with ischemic heart disease. So this ask about nifedipine. With nifedipine is we know it's dihydropyridine type calcium channel blocker. In calcium channel blockers, there are two types: dihydropyridines and non-dihydropyridines. Dihydropyridines mainly act peripherally, and non-dihydropyridines mainly act centrally. Therefore, dihydropyridine action mainly affect like peripheral vasculature and those stuff, vasodilation, those stuff. Then non-dihydropyridine action mainly occurs on heart, so reducing heart rate, contractility, those stuff. So in this stem asking, it's indicated in hypertension with ischemic heart disease. So as you remember, dihydropyridine types like nifedipine, amlodipine, those they have an adverse effect called uh, reflex tachycardia. So what does this reflex tachycardia means? Like they act on peripheral vasculation and cause vasodilation. Therefore, like suddenly as a reflex, heart rate will increase to concentrate that drop of blood pressure. So when a patient with hypertension, ischemic heart disease given nifedipine, so it can worsen ischemic heart disease because this may reflex tachycardia effect. Because tachycardia can worsen this heart cases, so it is not a good option in patient with ischemic heart disease. But like in lecture slide, there was something like comparison between nifedipine and amlodipine. I think Priyanka sir did it and he told amlodipine is less adverse effects than nifedipine. So in this case, we can use amlodipine, but nifedipine we can't use. So the stem is false, right? So B, beta blockers should not be combined with dihydropyridine calcium channel blockers. It's obviously false. No? Like we can do it. So false. Uh, Indapamide indicated in the treatment of hypertensive patients with type 2 diabetes. So it's asked about indapamide. Indapamide, indapamide is thiazide-like diuretic. Okay. So in thiazide diuretics, mainly there's an adverse effect called hyperglycemia in thiazide diuretics, but in thiazide-like diuretics, that effect is quite less. So in these conditions, we can use thiazide diuretic in hypertension with diabetes patients as well. So, so the stem should be true. The reason is because it's thiazide-like diuretic, not a thiazide. So the hyperglycemic effect is far more less than thiazide. In these patients, we can't use hydrochlorothiazide and those stuff, but indapamide and chlorothalidone, those we can use. So it's true. D. Methyl dopa can cause depression. So methyl dopa is centrally acting agent we can use in hypertensive conditions, mainly pregnant mothers. So as you remember, methyl dopa is also like it precursor of dopamine, which acts on central nervous system. So methyl dopa can cause depression as well as it can cause drug-induced Parkinsonism also. So this thing is true. Then hydrazine is indicated in preeclampsia. So hydrazine indications, this I took from lecture slide. Indication they specifically say hypertension and eclampsia and preeclampsia. So it's kind of a minor detail, but it's true. Hydrazine can be used in eclampsia and preeclampsia conditions as well. Okay, so this is some specific points I took from antihypertensive lecture. Like as you know, antihypertensive agents can be divided to primary and secondary. Primary ones are thiazide and thiazide-like diuretics, ACE inhibitors, ARBs, and calcium channel blockers. All other things are secondary. Okay, then this thing is quite asking MCQs, especially. So as you can see, ACE inhibitors and ARBs can be used in all of these conditions: heart failure, post myocardial infarction, diabetes, and CKD. And in MCQs, they specifically ask about these two: diabetes and CKD, because ACE inhibitors and ARBs has a renoprotective effect on kidney. So we can use hypertensive patients with diabetes or chronic kidney disease. Mm, yeah. Other than that, calcium channel blockers, mainly dihydropyridine type. Dihydropyridine means the best one is uh, amlodipine. So amlodipine can be used in these conditions, right? Those are the special things. Other things, beta blockers and aldosterone agonists, they won't ask in MCQs. But ACE inhibitors, ARBs, these renoprotective agents, is frequently asked. Okay, okay. Then I discussed this thing and the hypertension and pregnancy. So in pregnancy, we can't use ACE inhibitors, angiotensin receptor blockers, and thiazides. The one we can use is methyl dopa and labetalol. Okay, and the other thing is hypertensive emergencies. In hypertensive emergencies, esmolol, metoprolol, labetalol, and nitroglycerin, nitroprusides, those can be used. So frequently, the most rapid action is on metoprolol and esmolol, right? These are some things like they ask in MCQs frequently. So they were mentioned in this question. So right, just giving 1 minute. Sorry guys, I forgot to share my document, so I send it to Givat. He'll share you. So let's continue this. Okay, where were we? Alright. We discussed about beta blocker testing, right? So then STEM E statins are indicated regardless of baseline LDL level. It's true, right? In ischemic heart disease management, we can say the first line drugs are this also I taken from the lectures, right? Beta blockers, verapamil, diltiazem, and like calcium channel blockers mainly, and short acting nitrates, right? Then every patient who comes with MI, myocardial infarction, like you may have seen it in wards as well. So they are giving antiplatelet therapy mainly aspirin and clopidogrel, and lipid lowering therapy mainly using statins, atorvastatin, and sometimes they give ACE inhibitor or ARB as well. So the STEM is saying statins are indicated regardless of baseline LDL levels. It's true because it's kind of prophylactic thing against MI. So in myocardial infarctions, uh, there are survival benefit on these drugs. Antiplatelets, antiplatelets drugs like aspirin and clopid. Then other thing is anti-hypertensive drugs, not anti-hypertensive like drugs acting on renin-angiotensin, like ACE inhibitors, ARBs. Then statins. Those are the main drugs we can use in MI. There are survival benefits on these drugs. So the STEM is saying statins are indicated regardless of baseline LDL level. So it should be true. Okay. Then question number 33. Which of the following have proven survival benefit on the patients with heart failure? This is like a famous question. So in heart failure, there are four drugs which have mortality and survival benefits. Four drug classes. They are one is the drugs acting on the RAS renin-angiotensin system, which is inhibitors and ARBs. Then beta blockers. The second one, third one is mineralocorticoid antagonists like aldosterone receptor. Sorry, mineralocorticoid receptor blockers means like spironolactone. And the fourth one is SGLT2 inhibitors. SGLT2 inhibitors like empagliflozin. So the question is purely asked from these categories. Like if you know these categories, we can easily answer this question. So first one is digoxin. Digoxin is anti-arrhythmic drugs, so it should be false. Then enalapril. Enalapril is ACE inhibitor, so it is true. Then nicorardil. Nicorardil again we can use in MI patients, but not including these categories, so it should be false. Then empagliflozin is the SGLT2 inhibitor, so it's true. Then ivermectin. Ivermectin also not included in this list, so it should be false. So just remember, in patients with heart failure, we only the survival benefits can be seen with these four classes: drugs acting on renin-angiotensin system, beta blockers, spironolactone, and SGLT2 inhibitors. Okay, this is the same thing I told in the previous slide as well. Okay. Question number 34. Regarding antidiarrheals, first line management of acute gastroenteritis in children. So, like in acute gastroenteritis in children, this is mainly infective condition. So, diarrhea is not the disease. Diarrhea is a symptom. So, the disease is acute gastroenteritis. So, the management of acute gastroenteritis or anything like the symptom, if the symptom is diarrhea, we have to treat the infection, not the symptom, right? So, like just imagine patient, child with acute gastroenteritis. Like we have to manage acute gastroenteritis, and thereby it will settle the diarrhea condition. Like in this child, like we can use some antibacterial agent. Okay, so what happens if we give an antidiarrheal instead of antibiotic or something is diarrhea will settle but infection will still there. So the stem is false. First line management is treating acute gastroenteritis with antibiotic or like depending on the infection. If the viral, we should give proper treatment. So antidiarrheal is not the first line management for acute gastroenteritis. Just remember. Okay. Then loperamide has anticholinergic effects. Okay. So in antidiarrheals, we have three main antidiarrheals: codeine, loperamide, then cofintrol. Codeine is direct, like it act on opioid receptors and reduce peristaltic movements and thereby relieve the diarrhea. Loperamide also act on opioid receptors, but it acts directly on longitudinal and circular smooth muscles on intestine. Right? Then cofinotrope is a mixture of diphenoxylate and atropine. Atropine, you know, is antimuscarinic one. Uh, so in this stem is asking, loperamide has anticholinergic effects. Loperamide, the it do not have anticholinergic effect. The one with anticholinergic effect is cofinotrope because it's a mixture of diphenoxylate and atropine. So atropine is anticholinergic drug. So from this atropine component of cofinotrope, it elicits anticholinergic effects like dry mouth, tachycardia, those stuff. So this term should be false. Uh, yeah. C. Meberine hydrochloride has antimuscarinic effects. I think it's the same thing, same effect asking. It is also not anticholinergic. It's anti. I think it's given for spasm, like antispasmic drug. So it do not have antimuscarinic effect. That's not an important point in this question. Mm, okay, next one. Paralytic ileus is serious adverse effect of loperamide. Yeah, it should. It's true. Loperamide side effects like just remember in loperamide CNS penetration is very minimum. Therefore, CNS adverse effects are rare. But still, it has adverse effects including dizziness, drowsiness, and some serious effects like paralytic ideas and QT prolongation. So this STEM is asking about paralytic ideas. So it should be true. E. Hyoscine can be used as antidiarrheal. So hyoscine is antimuscarinic drug. So it can be used as antidiarrheal because so when an antimuscarinic effect occur, it will reduce peristaltic movements and thereby improve diarrhea. So we can use as antidiarrheal, but it's not an first line antidiarrheal drug. Okay, just remember it like that. Yeah. Other than that, you should remember about like mainly you should remember about codeine and loperamide. They don't usually question about coffee or rope. codeine and loperamide. These the main things. Okay. So question number 35 regarding thrombolytic agents. Second generation drugs have less fibrin specificity than first gen drugs. Like it should be anyway false, like the generation is superior. So superior means second generation is after first generation. So there should be improvements than first generation. So as in thrombolytic agents, the splicing specificity is increased when we come to the second generation. So the stem is true. Uh, yeah. Then tissue plasminogen activators stimulate fibrinolysis in the absence of extensive breakdown of coagulation factors. Like tissue plasminogen activator, like tissue plasminogen activator is the one activate plasminogen to plasmin. When plasmin get activated, it will uh, cause fibrinolysis. So yeah, so tissue plasminogen activator can if we can activate tissue plasminogen activator, it can stimulate fibrinolysis instead of like without coagulation factor breakdown. So it should be true because like plasminogen activator is kind of like sole agent stimulating activation of plasminogen to plasmin. So it should not need this extensive breakdown of coagulation factors. If we can activate plasminogen, fibrinolysis will occur. So STEM is true. Then streptokinase cannot be used after 4-5 days of first dose. Yeah, it's true. Like in streptokinase, uh, in this slide, you can see streptokinase should not used again after 4 days of giving first dose. Mainly, it's not given until 1 year, right? So the stem is true. Urokinase can be used. So urokinase cannot be used to lyse pulmonary emboli. It's false. Urokinase can use because it's also a thrombolytic agent. Its main indication, like yeah, pulmonary emboli is an indication for urokinase use. So the stem is false because its stem cannot use. Then alteplase is given as an IV bolus. Now, this is another famous question. Alteplase and tenecteplase. Alteplase is mainly used in stroke conditions, ischemic strokes, and tenecteplase mainly used in ST-elevated MI conditions, right? So in alteplase, we should administer it as bolus followed by infusion. But tenecteplase, we can give it as IV bolus. So the question is asking about alteplase is given as an IV bolus. It's true because alteplase is given bolus followed by infusion. They do not say like given as only bolus or something. They're just saying about can give as IV bolus. So it should be true. Uh, the other thing I forgot to tell is streptokinase administration. Streptokinase also given as IV infusion, right? Dose I don't think it's necessary to remember, but the way of administration is asked in MCQs. Tenecteplase IV bolus, alteplase bolus followed by infusion, streptokinase is IV infusion. Okay. Question number 36. Which of the following are true? This question is from B12, vitamin B12 complexes. Methylcobalamin is a preparation of vitamin B12. It's obviously true. Ne? Cobalamin is B12, so it's true. Post-gastrectomy patients will benefit from oral B12. Uh, what happened in post gastrectomy. Post gastrectomy means like stomach is removed, so they don't have stomach. In to vitamin B12 to absorb, we need intrinsic factor. Intrinsic factor is secreted by stomach. So in patients with post gastrectomy, they don't have stomach, so intrinsic factor secretion is impaired. So oral B12 absorption is also impaired. Therefore, we cannot use oral vitamin B12 in those patients. So we should have to go for parenteral preparations, not oral. So the stem is false because this post gastrectomy. Then hydroxycobalamin available as IM injections. It's true. Then erythropoietin is given for cancer patients. This is kind of tricky question, like 50-50 question again, because erythropoietin, it's given to stimulate erythropoiesis if in the patients with cytopenias, mainly anemias. In cancer patients, in some malignant cancer, there can be anemia. So we can give erythropoietin, but it doesn't mean like all cancer patients take erythropoietin, right? So there are some cancers which can cause anemia and reduce RBC formation. So in these patients, we can use erythropoietin. But all cancer patients do not need to get erythropoietin if their red cell count is normal. So the claim is saying erythropoietin is given for cancer patients. So we can mark it as true. But remember, not all cancer patients should take erythropoietin. Right? Erythropoietin is only given if the patient has anemia due to that specific uh, carcinoma. Right? E. Folic acid is given as 400 microgram tablets for pregnant women. It's true because folic acid should be given to pregnant women after knowing pregnancy as well as preconception period, because folic acid deficiency can cause neural tube defects on the fetus. So pregnant mothers has to take folic acid alongside with iron, calcium, and those stuff. So the stem is correct. Okay, question number 37. Regarding insulins, it's indicated in diabetic ketoacidosis. So in insulins, mainly what we should know is insulin is mainly given for DM type 1. That means diabetes mellitus type 1, where there is absolute insulin deficiency. Of course, beta cells in the pancreas is disrupted, so the pancreas cannot secrete insulin now. So we have to replace insulin. So in insulin, there are few types. Uh, these are the types. Like we can divide it as rapid acting insulin analogs, short acting insulins, intermediate acting insulins, long acting analogs, and biphasic or premix insulin. So among these preparations, we should have to know which preparation to use in which conditions. Okay. So in diabetic ketoacidosis is a complication of diabetes mellitus type 1. There are mainly two complications. One is diabetes ketoacidosis, other one is hypoosmotic hypoglycemic state. So therefore, in diabetes ketoacidosis, we can use insulin. Mainly like diabetes ketoacidosis and hyperosmotic hyperglycemic state, those are like emergency conditions of diabetes mellitus. So in these conditions, we should use a intravenous preparation of insulin. So many insulin preparations are available as subcut. The one we should use here is intravenous. So, like in our list, only one intravenous preparation is regular insulin or soluble insulin. Okay, IV soluble insulin. And another thing to remember is soluble insulin is like kind of identical for normal human insulin. Okay, so the stem is true. And then B, it's about soluble insulin. Soluble insulin is short acting. It's true. Right? Regular or soluble insulin is short acting, but it's not an analog. Okay, short acting analogs are another type. Soluble insulin is a different type. Then insulin glargine is rapid acting. It's false. Insulin glargine is long acting insulin analog. Insulin glargine, degludec, and there was another type, insulin detamia, I think. They were long acting. Short acting insulin analogs are insulin lispro. Okay. Then is administered subcut routine. It's true. In DM1 patients, they should administer subcutaneous insulin 3 or 4 times depending on their demand. So the system is true. Isoprene appeared cloudy. This isoprene insulin is intermediate acting insulin type. So this is kind of practical question. So as you can see, intermediate acting insulin and long acting insulin. This isoprene is also intermediate acting insulin. These both types are cloudy, cloudy solutions. So like whitish color solution. We can like if we take that cartridge, we can see it's white color cartridge. On the other hand, those other types like short acting insulins, biphasic means premix insulins, rapid acting analogs, long acting analogs, those are clear solutions. Intermediate acting and long acting insulin are only insulins which appears cloudy. So the stem should be true. Isoprene insulin is cloudy, yes, true. These are some other points we should remember about the insulin. Like I don't go through these all, but like needle length and injection site rotation, then pinching up methods and patient advice. Like you should know about these stuff because patient advice वगैरह ना like they can ask it in SCQs as well, right? So it's important to know. Okay, regarding steroids, hydrocortisone is a naturally occurring steroid. Should be false. Naturally occurring steroid is cortisol, not hydrocortisone. So it's false. Dexamethasone is used to induce lung maturation. It's true because uh, in mothers who can deliver baby prematurely, like premature means 24 to 28, 30 weeks now. Uh, so we know in a fetus we need surfactant to maintain lung function. So this surfactant maturation usually occur around 28 weeks. I can remember. So if a mother is at risk of premature delivery, we should give uh, dexamethasone. So dexamethasone it can induce lung maturation by like improving surfactant secretion because we need the fetus needs surfactant to maintain lung function. If the baby is gonna deliver prematurely, if the surfactant maturation is not occurred, baby can uh, undergo respiratory distress and he can die also. So to prevent that, in the mothers at risk of premature delivery, we should give dexamethasone to improve their lung maturation, specifically by stimulating this surfactant secretion. That's the point of this stem. Then C can cause purple abdominal stripe. Okay. Uh, in glucocorticoids, right, there are many side effects. Like all of them, we can't remember. The thing is, like we can categorize them as like this, like musculoskeletal, renal, respiratory, GI, metabolic, immunological, and so on. So the way you should do is like just remember one or two for each category. It will be easy. Like most common ones for those categories, like in CNS system now, sleep disturbance, then another like euphoria or something. In skin now, acne, then purple striae, those stuff. ඒ වගේ you should remember some important side effects of that system. So thereby you can remember how many adverse effects of glucocorticoids because it is a frequent area of questioning, specifically in MCQs. So abdominal striding is true. Skin swelling, it can cause abdominal purple stripe. Then dose should be increased in long-term steroid users during infection. So infection is kind of a stress condition for body. So long-term steroid users, like steroid can be used as replacement therapy. So like we are mimicking the normal circadian rhythm. So if the person get an infection, so he's on stress condition. So therefore we have to increase cortisol dose. So the stem is saying dose should be increased in long-term steroid users during infection. So therefore, STEM is true because infection is a stress condition. We should increase the dose, glucocorticoid dose. Specifically, we are using cortisol, so we should increase cortisol dose. It's true. Prednisolone can be used in pregnancy. This thing, this paragraph I took from SLS, it will say uh, betamethasone and dexamethasone can cross placenta. So if it can cross placenta, that means it can may transfer to the fetus and cause some side effects and those stuff. But prednisolone does not. Prednisolone can't cross placenta. Therefore, in pregnant mothers, prednisolone is quite safe to use than other glucocorticoids like dexamethasone, betamethasone, those stuff. So the stem is therefore true. Other than these things, you should have to know about patient advice regarding glucocorticoid use and those stuff, specifically adherence, tapering off, and how to take them during an infection, those stuff. Because like also like in insulin, insulin, this thing also can be asked in MCQs as well as SCQs as well. So to be remembered. And the other thing is the types of glucocorticoids. Like as you can see, the efficacy of glucocorticoids aren't same. So like hydrocortisone, the efficacy of hydrocortisone is less than prednisolone. Like the most efficacious one is dexamethasone. Like yes, you should have a rough idea about this thing. Like which one has high efficacy, which one has low efficacy, this thing. Okay, uh, that's that. Then question number 39 regarding drugs in Parkinson's disease. So Parkinson's disease, we know it's a condition where uh, dopamine deficiencies they are in linear, sorry, linear, not linear, substantia nigra. So the dopaminergic neurons are deficient of dopamine. So what we should do is we should replace dopamine. So to replace dopamine, we can't give dopamine alone because dopamine, like dopamine cannot cross blood-brain barrier. Therefore, we should use dopamine precursor. The one we using here is L-dopa. That means levodopa. Levodopa can cross blood-brain barrier and enter central nervous system. Then in but there's a problem. The problem is L-dopa can be converted to dopamine by dopa decarboxylase. I think the enzyme. That enzyme is also there in the periphery as well. So if we give L-dopa alone, most of L-dopa will be converted into dopamine at the peripheries. So therefore, like the amount crossing to CNS system is less. Therefore, we give carbidopa. Carbidopa is dopa decarboxylase inhibitor, specifically peripheral dopa decarboxylase inhibitor. When L-dopa given with carbidopa, uh, the peripheral dopa decarboxylase, uh, dopa decarboxylase activity will be impaired. Therefore, the CNS absorption will be more. So the stem is saying peripheral decarboxylation is inhibited by carbidopa. It's true. That is the point of using carbidopa alongside with levodopa. Then B, propirenol is used in first-line treatment for mild disease of young means young patients. So in this condition, yeah, uh, usually in long-term treatments, we should use levodopa and peripheral dopa decarboxylase inhibitor, which is carbidopa. But the problem is there can be tolerance after 4 5 years of levodopa using. So therefore, levodopa should be like kind of uh, reserved drug for old age because like in older adults, like old adults, we should use levodopa and carbidopa. But in young patients, we can try some other medications like dopamine agonists. Dopamine agonist is this propirenol and those stuff and monoamine oxidase B inhibitors. Okay. Uh, so the STEM is saying propirenol is used first line treatment for mild disease in young. So it's true because propirenol is dopamine agonist. In young patient with Parkinson's disease, we usually use propirenol for first line treatment because levodopa is reserved for all patients. So then COMT inhibitors are effective as initial therapy. COMT inhibitors means catechol or methyl transferase inhibitors. In these medications, like we can't use them as monotherapy. That's the problem. There should be dopamine precursor or dopamine uh, agonist alongside with this. So as an initial therapy, we can't use it. If we can combine with that dopamine agonist or precursor, we can, but as a monotherapy, we can't. So it's false. On and off phenomenon is usually seen within first year of disease. So this on and off phenomenon, uh, yeah, on and off phenomenon is a condition where when the patient start to take dopa, carbidopa and levodopa, with the time, like between doses, there are motor fluctuations, right? So these motor fluctuations are known as on and off phenomenon. So this phenomenon to occur, there should be some time range. Okay, it won't occur in first year, like especially it occur, I think, after 4 5 years of using. That means long term usage. The question is asking within first year. So it should be false. On and off phenomenon usually seen within patients who are taking dopa, L-dopa and carbidopa for long time. That means 4 or 5 years is false then. Question E. Benzexol is used in treatment of drug-induced Parkinson's. So the other type of Parkinson is drug-induced Parkinsonism. Uh, these are the drugs that can cause Parkinson's, dopamine receptor blockers, methyl dopa, synergine, amiodarone, those things. And the treatment is Benzexol. Benzexol is anticholinergic. So we can use Benzexol as treatment for drug-induced Parkinsonism. So the stem is true. Uh, that other than these things, uh, so the question asked about on and off phenomenon. So other than these things, those some questions asked about this hypokinesia, tremors, and those stuff. So in hypokinesic conditions, we should use like levodopa because like hypokinesia occurs due to lack of stimulation. So to increase those stimulation, we should use some dopamine precursor like levodopa. Other than that, uh, we talked about this old adult thing and young patient thing. Uh, other thing is amantadine can be used in dyskinesias. Right? Those are some minor points like might ask for MCQs. So yeah, that's that. Then question number 40. It's asked about morphine, which is opioid. Okay. The whole question is about side effects of opioid, specifically morphine. Right? In opioids, we have to know this mechanism of action because it's frequently asking SCQs, right? Like it decrease release of substance P and other nociceptors, nociceptive neurotransmitters, then impair nociceptive neurotransmissions and activating descending inhibitor pathway. Those things you should know because they are asking SCQs. So the question is asking about side effects. So specifically in morphine, respiratory depression, nausea, vomiting, constipation, hypotension, bradycardia, those side effects are there. Like they all are there for other opioids as well, but specifically for morphine, there can be biliary colic. It is due to biliary spasms and urinary retentions. Those are some special side effects of morphine. So the question is asking those stuff. Morphine causes A. Increased salivation. It's false because morphine causes dry mouth. Then biliary spasm. It's true, I think, because they are in this list as biliary colic is due to biliary spasms. Then respiratory depression. It's true because most opioids can cause, like in toxicity, they can cause respiratory depression. D. It can diarrhea. It's false, like because Morphine and other opioids cause constipation, not diarrhea. So it's false. Then hypotension. It's again, hypotension is true. I think it was there. Yeah. Hypotension and bradycardia or tachycardia can be there with morphine. So other than these adverse effects, you should know about tolerance and dependence of opioids, specifically in morphine. So I don't like go through these stuff. So, but you should know about this thing. Other than morphine, the special opioids that are asked in MCQs are pethidine, fentanyl, and there was another one. Pethidine, fentanyl, and tramadol. Yeah, those three. ඒ තුන් දෙනාගේ special side effects you should know. Like in pethidine, we cannot be used with Parkinsonism who are using monoamine oxidase B inhibitors. Like that, there are some special points you should know. Other than that, the main thing is morphine. Okay, yeah, that's done. Then regarding local anesthetics, A, lipid solubility is proportional to potency of the drug. So, local anesthetic, that drug. uh, So, to local anesthetic to add, there should be like in a cell, like just imagine this is cell and this is lipid bilayer. There are some ion channels, right? To local anesthetic to act, it should be entered into the cell, right? If the lipid solubility of cell is increased, they do not need to go through these channels. They can go directly through the cell membrane because it's lipid soluble plasma membrane එකේ තියෙන lipids. So therefore, they can go into the cell membrane through the cell membrane into the cell. So the term is saying lipid solubility is proportional to potency of drug. That should be true because lipid soluble get increased, the amount of drug that dissolve diffuse into the cell is increased. Therefore, the effect is more. So it's true. They exert their action by inhibiting voltage gated potassium channel. False. Its action is mainly inhibiting voltage gated sodium channels. Right? Uh, C. Higher pK, higher the pKa, higher the potency. This thing, yeah, dissociation constant. It says like mainly local local anesthetics are uncharged bases. Okay, so most local anesthetics are at the range of pKa's are 7.5 to 9. That means like not high, kind of mild pKa range. The exception is this benzocaine, which has pKa of 3.5. Most are in mid range. So the question is asking higher the pKa, higher the potency. That means like if pKa is like 10, 11, its potency is high. It should be false because most local anesthetics are on pKa between 7.5 to 9. So this term is false. Then absorb well via mucous membrane. It's true. So mucous membrane is like membranes on eyes, then some cells. So therefore, some local anesthetics are available as eye drops, then ointments, gels. So that's because they can be absorbed through mucous membranes. The best example is lidocaine, lidocaine gel. I think like during catheterization, you might have seen it like they use lidocaine gel on catheter to induce local anesthesia because like in urinary tract those mucous membranes, uh, local anesthetic can be absorbed by those mucous membrane. Another example is local anesthetic eye drops. Uh, in cataract and other eye surgeries, they use local anesthetic. Mainly, it's not lidocaine, it's another type of local anesthetic. They use it as eye drops because they can be absorbed through mucous membrane of the eye. So it's true. Then duration of action is increased by giving with an vasoconstrictor. This is important. Yeah. Local anesthetic with vasoconstrictors. The main vasoconstrictor we use is adrenaline 1 to 200,000. So the use of this adrenaline is it mainly delay local anesthetic absorption. Then it will reduce systemic toxicity and also increase duration of action. Like it says double the duration, mainly increase duration of action. Other than that, in reduce amount of anesthetic required. So in dental anesthesia and those stuff, they use some higher strengths of uh, adrenaline than these conditions. So and another important point is avoid these adrenaline and other vasoconstriction in areas with end arteries like fingers, toes, nose, because like they are having end arterial supply. If we use adrenaline with adrenaline plus lidocaine for these areas, they can undergo vasoconstriction and those areas will be ischemic and then undergo necrosis as well. So we shouldn't use areas with end arterial supply for lidocaine plus adrenaline use. Then other than that, uh, yeah, those are the main things about local anesthetic with vasoconstrictors. What does the question ask? Yeah, it asks about duration of action is increased in giving it vasoconstriction. It's true, ne? Vasoconstrictor के duration of action increase करना, systemic toxicity reduce करना, um, reduce amount of required local anesthetic. The last one is double the duration of action. So the stem is true. Other than these stuff, you should know about this ideal anesthetic, these characteristics. I think, yeah, 7 characteristics of ideal anesthetics: soluble, stable solution, sterilizable by heat, rapid onset, those stuff. They are sometimes asked in SCQs, like so. You should have to know. Other thing is precautions. So as I said before, local anesthetic with vasoconstrictor cannot be used in areas with endarterial supply. So other precautions are cannot use in infected tissues, like because these are local anesthetics are weak bases. So in infected tissues, like in infections, there are acidosis and those stuff. So in those spaces, we give a weak base. It will react with those acids and may get dissolved. So the local anesthetic action won't act there. Therefore, we can't use local anesthetics in infected tissues. The other important precaution is avoid inadvertent intravascular injections. If we inject two vessels, it can undergo systemic toxicity and cause more harm. Okay, so yeah, there are other few precautions as well. Main ones are those stuff. Okay. Question number 42 true false. A infusion of GnRH agonist can increase LH and FSH secretion. Mm, this question, like if we consider like infusion, it can be continuous or pulsatile. If the infusion is pulsatile, like it will mimic normal circadian secretion of GnRH. So therefore, it can increase FSH LH secretion. But the infusion is continuous, it can elicit suppressive effects. So therefore, it will reduce FSH LH secretion. So question specifically don't say about this pulsatile or continuous thing. So yeah, only telling about this infusion. So if we consider its continuous infusion, it will reduce FSH/LH. Then this term should be false. So if we consider it is as pulsatile infusion, it will increase FSH/LH secretion and stem should be true. So therefore, like we can't give a answer for that stem. Mm, yeah, the danazol has a weak androgenic action. It's true because danazol can cause feminization and some other androgenic action on women. Then metformin is used in treatment of PCOS. It's true. Metformin metformin main use is it's used in non-insulin treatment for diabetes. Other than that, it can use polycystic ovarian syndrome as well. So it was there in the lecture slide. Gonadotropin can be used to stimulate FSH and LH. It should be LH and FSH. So gonadotropin is actually GnRH agonist, I think. So it can stimulate FSH secretion if we mimic circadian rhythm. So it's true. NSAIDs are indicated in treatment of abnormal uterine bleeding. True. Main NSAIDs we use is mefenamic acid. You can remember it as mefenamic acid for menstruation. M4, right? So the stem is true. It can be used in abnormal uterine bleeding. This lecture is kind of like this GNRH theoretical lecture kind of lecture but we have to know this stuff. Like because they are asking in MCQs. Some small stuff. Mainly you should know about this GNRH agonist, then somatostatin and somatotropin agonist, and cortisol. Those are the main areas they question from that lecture. Okay. Question number 43. Medications and their use is therapy. These are the medications that used in obstetric conditions. So let's see. A. Misoprostol, termination of second trimester pregnancy. Uh, misoprostol is PGE1 again. PGE1 type. So in prostaglandins there are three types in that we are using in obstetric conditions, and those are PGE1, PGE2, and PGF2 alpha. So misoprostol is PGE1. The PGE2 one is dinoprostone, and PGF2 alpha ones are carprost and dinoprostone. So the use of PGE1 is termination of second trimester pregnancy. That means like kind of medically induced abortion. So the stem is true. It can be used in second trimester, termination of second trimester pregnancy. Then carboprost. Carboprost is also uh, it's also a prostaglandin which is PGF2 alpha type. They are mainly used in PPH, that means postpartum hemorrhage conditions. So the stem is saying augmentation of labors, it should be false because they are used in PPH. False. Then ergometry. Augmentin is ergot derivative. It can use in TPH because like in postpartum hemorrhage, augmentin has two effects. One is it will increase uterine muscle tone and thereby improve vasoconstriction of uterine vessels. Other than that, it will directly cause uterine vasoconstriction. So thereby it can prevent postpartum hemorrhage. But the drug of choice for PPH is oxytocin. Drug of choice is for PPH is oxytocin, but augmentin can be used for PPH. And also those PGF2 alpha, those stuff also can be used in PPH. Then oxytocin, induction of labor. It's true, oxytocin can be used for labor induction mainly if the cervix is favorable. Because to oxytocin to act, there should be estrogen. So mainly estrogen secretion increase near the term. Therefore, in favorable conditions, like near the term, the estrogen level increase, those incidences, oxytocin can induce labor. But in preterm labors, oxytocin cannot use to induction of labor. In those situations, we should use prostaglandin, like dialposterone. Yeah. Then E, ritodrine, prevention of premature labor. It's true. All of these stuff we call discuss the uterotonics. Ritodrine is tocolytic. That means uterotonics are the drugs that increase uterine contraction. Tocolytics are drugs which reduce uterine contraction. So ritodrine can be used for prevent premature labor because it will reduce uterine contraction and prevent premature labors. So it's true. I think I discussed the stuff oxytocin uses as well. Another thing is I told oxytocin can be used for BPH as well. So for PPH, oxytocin used in IV bolus form. So in augmentation or induction of labor, oxytocin used as slow infusion, right? Uh, Other things I discussed. Okay, regarding DMARDs. A. Sulfasalazine inhibits cytokine production. It's true. Sulfasalazine will act on macrophages and other inflammatory cells and reduce cytokine production. But its action is mainly like it's not well understood, but it's known to reduce cytokine production. So it's true. Hydroxychloroquine can cause retinal toxicity. It's true. Like uh, in hydrox, like in DMARDs, mainly conventional DMARDs, there are four methotrexate, hydroxychloroquine, then sulfasalazine and leflunomide. Among them, hydroxychloroquine's most or its side effect is this retinal toxicity. That's why the patients who are about to start hydroxychloroquine should be monitored for visual defects and those stuff. Therefore, they should prefer for eye checkups. And after starting hydroxychloroquine also, the eyes should be monitored. And on the other hand, sulfasalazine, the most worried side effect is SJS. SJS means Steven Johnson syndrome. Other than that, it can cause those crystalline nephropathy as well. Then methotrexate and lexonomide, those stuff, they can cause anemias, mastocytosis, lung fibrosis, those stuff. So yeah, in this question says hydroxychloroquine can cause retinal toxicity, so it's true. Then infliximab is interleukin 6 receptor blocker. It's false. Infliximab is anti-TNF alpha 1. So it's false. Interleukin 6 inhibitor is, I think, rituximab, not infliximab. Infliximab is anti-DNF alpha. Then JAK inhibitors are targeted synthetic DMARDs. It's true. JAK inhibitors are targeted synthetic DMARDs. So in DMARDs, like we know, there are three types: conventional DMARDs, biologics, and targeted synthetic. JAK inhibitors are one of them, targeted synthetic ones. Then biologic DMARDs are administered subcutaneously. We got two. Yeah, that's that. Then question number 45 regarding NSAIDs. Combination should not be used in rheumatoid arthritis. It's true. NSAID combinations are not used in most instances. It's kind of contraindication. We don't use two NSAIDs simultaneously. Then diclofenac sodium suppositories can cause gastric irritation. Diclofenac sodium, that means NSAIDs can cause gastrotoxicity. Okay, so it is due to systemic effect, not a local effect. Like if diclofenac sodium suppository is given, it will absorb to the vasculature and may it can cause these systemic effects. Like mainly gastric irritation is due to when NSAIDs go to gastric mucosal cells. Those mucosal cells produce mucosa and bicarbonate and those stuff, which will protect it against high HCl and other pepsin and other irritants. When NSAIDs go there, NSAIDs will inhibit cyclooxygenase enzyme and thereby inhibit prostaglandin secretion. When prostaglandin secretion inhibited, it will inhibit those mucus secretion and other stuff. Thereby, that gastric mucosa is more prone to damage by gastric juice. Thereby, it can cause gastric irritation. So, when suppository given, the situation do not change. Like don't change. It's because this effect is due to systemic toxicity, not local. Okay. Then the inhibit cyclooxygenase pathway is true. It's a main mechanism. It's true. Then diclofenac sodium is known to cause renal impairment. This is another adverse effect of NSAIDs. In NSAIDs, there are four main adverse effects: gastrotoxicity, cardiotoxicity, renal nephrotoxicity, and hepatotoxicity. In this condition, nephrotoxicity, there can be multiple mechanisms. One is like hemodynamic alterations, and there are some more. So, me saying diclofenac sodium is known to cause impairment. So, it's true. Then, naproxen has a high thrombotic risk. Regarding this, yeah, this is comparison of NSAIDs mainly in GI adverse effects. So, because we can see naproxen like it lies quite higher place in CVS. So the stem is in naproxen has high thrombosis means high cardiovascular risk. So as you can see, it has low cardiovascular risk related to other NSAIDs. So the stem should be false. Okay. Then question number 46 regarding Kefraxon, IPD module. So A, acts by binding PBP1 and 3 and inhibiting cellulose synthesis. PBP1 3 are penicillin binding proteins, which our enzymes need to synthesis of bacterial cell wall. So ceftriaxone is beta lactam one, so it can inhibit PBB one and three. So it's true. Effective against pseudomonas. This should be false because uh, anti-pseudomonal cephalosporin is ceftazidime, I think, not ceftriaxone. So it's false. Then given as once daily dosing. Uh, this thing, when we take pharmacokinetics of ceftriaxone, it has long plasma half-life. Therefore, it's given as once a daily dose. So the stem is true. D. Dose adjustment required in renal impairment. In this case, ceftriaxone mainly excretes through bile. Therefore, it do not require renal like dose adjustment in renal impairment because it's usually majority of them excrete through bile. So it should be false. Then it can cause kernicterus in neonates. It's true because its excretion is through the bile. So if neonates has jaundice and the problems with their biliary metabolism, ceftriaxone can cause kernicterus. Question number 47. Aminoglycoside. It's inhibit bacteria cell wall synthesis by binding to 30S ribosome. Uh, this is false because yeah, it's true it bind to 30S ribosome, but it do not inhibit cell wall synthesis. Mainly when aminoglycoside bind to 30S ribosome, what happens is it will increase bacterial protein synthesis. So thereby it's true. Sorry, it's false. Then source concentration dependent killing is true. Among our uh, antibiotics in IPT module, there were uh, two concentration dependent killing ones, quinolones and aminoglycoside. Other ones are mainly uh, time dependent. Okay. Then well absorbed in gut. It's false. Aminoglycoside should be given parenterally because it's absorption. It's water soluble one. So it cannot be absorbed through GI tract. E. Both peak and trough concentration should be monitored in once daily dosing. This should be false because peak and trough concentration. Trough concentration means concentration before the next dose. Peak one is concentration after the dosing. So these concentrations should be monitored mainly in conditions like infective endocarditis, like the conditions where we should use aminoglycosides as three TDSO that like has three doses per day like that. So in once a day dosing, usually don't need, but if we have to use three times a day, in that incidences we should monitor these peak and trough conditions, the concentrations. So it's true. So it's false. Then ototoxicity is irreversible. It's true. In aminoglycoside, there are I think four main adverse effects: irreversible ototoxicity, reversible nephrotoxicity, then there were the two, I think, myasthenia gravis precipitation, and there was something else. So the one you should remember is ototoxicity is irreversible, and the reversible one is nephrotoxicity because this aminoglycoside can act on tubular cells and damage them, but tubular cells can be regenerated. Therefore, this damage is reversible. On the other hand, ototoxicity is irreversible. Okay, cotrimoxazole contains sulfamethoxazole and trimethoxazole. Then it's bacteriostatic. It's false. When we take individually sulfamethoxazole and trimethoxazole, both of them are bacteriostatic. But when we use it as a combination in cotrimoxazole, it's bactericidal combination. So therefore, it's false. Used in no cardiosis. It's true because when we take indications for cotrimoxazole, so you can see it can use against pneumocystis infections, nocardiosis, myeloidosis, diarrheas, and those stuff. So like ഞങ്ങൾ unusual organisms ലായിട്ട് പഠിക്കുന്നു again. So other than these infections, it can act against these species as well. But it is resistant to these infections, Pseudomonas, tuberculosis, Treponema, Campylobacter, rickettsial infection. For those infections, cotrimoxazole is cannot use. They are resistant to cotrimoxazole, but in these conditions, we can use cotrimoxazole. So, nocardiosis is true. Then, cause for Steven-Johnson syndrome. It's true. Cotrimoxazole adverse effects mainly we can see crystalluria, nephrotoxicity, hypersensitivity reactions like rashes, SJS, hemolysis in G6PD, those stuff are there. So the most adverse effect we worry is Steven-Johnson syndrome. So this is true. Contraindicated in pregnancy, it's true. Cotrimoxazole and quinolone both are contraindicated in pregnancy. Mm, I discussed this stuff. The other thing is about these individual sulfonamide. You should like sometimes they ask about sulfadiazine, sulfadoxime, and sulfadiazine, like the indications like sulfadiazine used alongside with pyrimethamine for toxoplasmosis. Sulfadoxine used with pyrimethamine with malaria. Sometimes they ask those questions. Therefore, you should have an idea about it, like rough idea, not in detail. Okay. Question number 49. Quinolones inhibit bacterial DNA gyrase. It's true. Quinolone mainly inhibit DNA gyrase, which is also known as topoisomerase type 2, and thereby inhibit DNA transcription. Then oral bioavailability is low. It's false. I think oral bioavailability is around 90-95%. Okay. So this is false. Used in treatment of UTI in pregnancy. So I told previously as well, quinolones and cotrimoxazole both are contraindicated in pregnancy. Then used in multi-drug resistant TB. It's true, like in the regime, we can use Cipro. We can use ciprofloxacin for TB if it is multi-drug resistant. So it's true. Actually, tendon rupture is a side effect. So this is the famous side effect of quinolone, Achilles tendinitis. So it's true. Okay. 50 is about nitrofurantoin. Nitrofurantoin is urinary antiseptic. We can use in mainly lower urinary tract infections. Okay. The first one, damage DNA by inhibiting various enzymes in bacteria. It's true. Then B, poor oral bioavailability. It's false. It's given as oral tablet. You may have seen it in words. It's a yellow color tablet. So it has good oral bioavailability. then rapidly excreted by tubular secretion. It's false because the excretion is not tubular. It should be glomerular. Sorry, glomerular filtration, not tubular secretion. Like it will filter from the glomerulus and achieve bactericidal concentrations in blood. Thereby, it will elicit effects. Then question D, effective against Proteus mirabilis. It's true. Ne? Proteus is one of those enterobacteria that can cause UTIs. The other ones are E. coli, Klebsiella, Proteus, and those stuff. So it's true. Then indicated for pyelonephritis. It's false because pyelonephritis is upper UTI in nitrofurantoin mainly used for low UTIs like cystitis, urethritis, and those stuff. So it's false. For pyelonephritis, we should use IV antibiotics, mainly ceftriaxone, cefotaxime, like 51. Yeah, pharmacology content is 10. 51. Which of the following are AIDS-defining illnesses? So this question asks us AIDS-defining infections. So AIDS-defining illnesses are infections. Infections occur due to severe immunodeficiency caused by AIDS. This severe immunoparesis means CD4 count is less than 200. Okay. So in these conditions, these opportunistic kind of infections can progress. These are some of them: pneumocystis jirovecii pneumonia, Kaposi sarcoma, candidiasis, CMV, and varicella infections. So this question asked about from them. Esophageal candidiasis is true. Is defining illnesses. Esophageal and vaginal candidiasis. Oral esophageal vaginal candidiasis. Oral hair leukopenia. This is false because oral hair leukopenia occur mainly during the early stage of immunoparesis, like not due to severe immunoparesis. It's kind of early sign of immunoparesis. Therefore, it's not an AIDS-defining illness because CD4 count is not less than 200 when oral hair leukopenia appears. Therefore, it's false. Then HIV encephalopathy is true. It's defining one. Pneumocystis pneumonia and Kaposi sarcoma both are true. It was there. The next slide. The thing you should remember is oral hair leukopenia is not an age-defining illness. Okay. Then regarding zoonosis, uh, Lyme's disease is called by Borrelia burgdorferi. It's true. Borrelia is, I think, a spiral bacteria. So it's true. Epidemic typhus is transmitted by bite of rat flea. This rickettsial infections now you should remember like they frequently ask about those host vectors and organisms. Like in epidemic typhus, organism is Rickettsia prowazekii and vector is Bodilus. So this question asks about epidemic typhus. So as you can see, epidemic typhus, its vector is Bodilus, not rat flea. Rat flea is the vector of endemic typhus. So the vector of epidemic typhus is Bodilus. Therefore, it's false. Salmonellosis is transmitted by contaminated food. It's true. It's obvious. Ne? Then Causative organism of Rocky Mountain spotted fever, Rickettsia rickettsii, can found in reservoirs in dogs. So it asks about Rocky Mountain spotted fever caused by Rickettsia rickettsii. So the hosts are small mammals like deers, dogs, and rabbits. Question asks about reservoirs in dogs. So it should be true. Right? Then anthrax caused by gram-negative bacillus. Anthrax is caused by, I think, Bacillus anthracis, which is gram-positive bacillus. Gram-positive, uh, gram-positive spore-forming bacillus. Therefore, it's false. This zoonosis lecture is kind of like the lecture. There are many small points and examples to remember. This is kind of a short note I made to study this thing, so you can use it if you want. So, but this thing about recursive infections, you should buy hard, okay? Because like it is a frequently questioning area of microbiology. Yeah. Then question number 53, typhoid fever. Stool culture can be positive in secondary. So this culture thing, we can remember it like this. Like, so the culture is the gold standard for uh, diagnosis of typhoid fever. So as alphabetical order, BSU, blood, stool, and urine. They get positive from blood from first week, stool second week, and urine third week. Therefore, them saying stool culture can be positive in second week should be true. You can remember it like this. Diarrhea is the commonest clinical presentation. It should be false because it presents as febrile illness, not as a diarrhea. Ne? It can be constipation or diarrhea, but present as febrile illness. Mainly, fever is in step-ladder pattern, as you can see in this picture. So the stem is false. Diarrhea anemia commonest clinical presentation. It is febrile illness. It's false. Then caused by Salmonella enterica serotype paratype. So this question is asking about typhoid fever. So it's false because paratype causing paratyphoid, paratyphoid fever. So it's false. Typhoid fever is by Salmonella enterica serotype typhi, not paratyphi. Okay, D causes smooth transverse ulcers along antimesenteric border of terminal ileum. It's false because those ulcers are linear ulcers. Linear ulcers along antimesenteric border because on the antimesenteric border we can see Peyer's patches. So these ulcers are mainly they are located over these Peyer's patches. Uh, transverse ulcers are mainly seen in TB intestine. So these are those linear ulcers along the antimesenteric border. Yeah. E. Carriers shed organisms in their stools or urine. It's true. You may have heard about the typhoid Mary story. So they can shed organisms in stool and urine. It's true. Yes, these I discussed these things. Main clinical presentations and step development. Okay, 54. Leptospirosis. Direct invasion of tubular cells by organism can cause acute renal failure. In leptospirosis, mainly there are two pathologic mechanisms. One is Direct invasion is other one is immunological reactions. Both of these mechanisms will cause tissue injury. The main type of tissue injury is capillary vasculitis. So it can cause endothelial dysfunction and thereby cause vasculitis. So this vasculitis will lead to other organ dysfunctions as well, mainly lungs, kidney, and liver and other organs as well. In kidney, there can be direct nephrotoxic effect to PCT, that means proximal convoluted tubule, as well as immunological response. So, other than that, this leptospirosis can cause uh, myopathies, myalgias, thereby they release myoglobin and cause myoglobinuria, which can cause AKI as well. So the question asked about direct invasion of tubular cells by organism can cause acute renal failure. So it should be true. So it is there. Direct effect can cause PCD damage. Okay, then some patients develop meningitis as a complication. Uh, as you know, leptospirosis, there are two stages, anicteric phase and enteric phase. Most patients, like roughly 90% patients, are present in anicteric phase, which lasts around 5 to 7 days, and it will resolve mainly. Some patients, like roughly 10% of the patients, they will progress into this other stage, icteric stage, which is kind of life threatening with some complications like meningitis, renal failure, liver failure, and seizures, those stuff. So, can we say some patients develop meningitis as a complication? So, it should be true. Mainly, it's icteric phase. Then, blood can be cultured in icteric phase for diagnosis. Uh, for this thing, blood culture can done, but the thing is, blood culture should be taken within 7 days of illness. Within 7 days of illness means it's not icteric phase, it's anicteric phase. In the icteric phase means after 7 days mainly. So in those situations, we should use other type like urine cultures, not blood cultures. So the STEM is saying blood can be cultured in icteric phase. So that's false. Blood culture won't give us good results in icteric phase. Then azithromycin is selective in treatment. It's true. Mainly in leptospirosis, main treatments are penicillins, ceftriaxones, and azithromycin, and main one is doxycycline. Azithromycin also can be used as well. Okay. Then direct contact with infected human urine lead to human-to-human transmission. It's false because no evidence about that. Discuss these things. Okay, 55. Which of the following give rise to thrombocytopenia in dengue? In dengue, there are three main things: thrombocytopenia, bleeding manifestation, and endothelial dysfunction. For thrombocytopenia, three mechanisms for it. One is decreased production, the one is increased destruction, and last one is increased consumption. So, production will be decreased due to bone marrow suppression due to some cytokines secreted during this infection, and increased destruction of platelets is due to maybe due to direct invasion by virus or can be due to macrophage activity. Then other one is increased consumption. This can be due to DIC, that means disseminated intravascular coagulation, where platelet consumption will increase. So the question is asking about thrombocytopenia. So first one is bone marrow suppression. It's true. It will suppress uh, synthesis of platelets. B. Disseminated intravascular coagulation. It's also true. It will increase consumption of platelets, so thereby cause thrombocytopenia. Then direct infection by virus. It's also true because this direct invasion by virus can cause direct platelet damage, direct platelet destruction. Then treatment is NSAIDs. NSA treatment mainly do not cause thrombocytopenia. This condition, so it's false. Then destruction by cross-reactive T cells. Mainly in dengue, platelet destruction is mainly due to macrophage activation and direct destruction by virus itself, not cross-reactive T cells. So it's false. So other than these things, pathogenesis of bleeding and endothelial dysfunction, they also can be questioned. So in dengue, these things can also be questioned in ACQs as well. So you should have a good knowledge about dengue. Okay, question number 56. Typhus. Regarding typhus, scrub typhus is transmitted by tick. It's false. Scrub typhus is mainly transmitted by thrombiculid mite larvae. So it's false. Then disseminated intravascular coagulation. DIC can occur with widespread endothelial dysfunction. It's true because in typhus, the main clinical manifestation is vasculitis and in DIC complications. So this vasculitis can cause microthrombi formation and those stuff, which can lead to DIC as well. So therefore, this is true. See, wheel Felix test is routinely used for diagnosis. It's false because the main test that we use for typhus is serological test like ELISA. Wheel Felix test we can, but the sensitivity and specificity is very low when we compare with the serological test. Therefore, in other countries, they don't routinely do these tests, but in Sri Lanka, in NHSL, they do these tests because I think less cost. The main gold standard for diagnosis is serology. Okay. Then hemorrhagic rash can be seen in epidemic typhus predominantly. So in this rickettsial infections, there are mainly two types, uh, typhus and spotted fever. In spotted fever, the rash is more predominant. Typhus rash is not predominant. They might present with scars or other stuff. So the question is asking about epidemic typhus. Epidemic typhus is typhus type, not a spotted fever type. So it is false because spotted fevers are the type present with hemorrhagic rashes. Typhus mainly present with scars. So it's false. Then chloramphenicol is an effective therapy. It's true because chloramphenicol can be used in rickettsial infection when it's resistant to other antibiotics. Okay, final questions. Parasite 57 regarding diagnosis of malaria. Rapid diagnostic test is gold standard for malaria diagnosis. For malaria diagnosis, mainly two tests, One is thick and thin smear. Thick and thin smear. Other one is rapid diagnostic test. Thick smear can be used to uh, see whether parasite is there or not, or and also if it is there, the count of the parasites. It will so used to see the counts and presence presence of parasite. On the other hand, thin smear, it's used to see the like fine details, the type of parasite and its stage, in which stage, ring stage, gametocyte or other. So the gold standard one is this. Thick and thin smear is the gold standard one. On the other hand, rapid diagnostic test, it is kind of screening test we can use because it only take around I think uh, 15 or 20 minutes okay tama. So the results we can take immediately. But the gold standard one is thick and thin smear. So the STEM is saying rapid diagnostic test is the gold standard for malaria diagnosis. Therefore, it's false. It's not the gold standard. Then B, thin smear assist in finding of parasite count. False. Ne? Thin smear will focus about fine details like parasite stage, parasite type, those stuff. Parasite count and presence can be seen from thick smear. Then thin smear is organism identification. It's true. Then HRP2 antigen in uh, rapid diagnostic test kits can distinguish Plasmodium vivax from other species. This HRP is histidine rich protein. Histidine rich protein type 2. This antigen mainly distinguish not vivax, uh, falciparum. Therefore, this is false. So, as you can see, histidine rich protein type 2. It mainly identify Plasmodium falciparum, gametocytes, and trophocytes. So, yeah, this is about the canteen smear. I told about it. Mm, therefore, STEM D is false. STEM E, molecular detection is beneficial in the diagnosis when parasite count is low. It's true. Ne? When parasite count is low, the chance of finding a parasite is less. Ne? Therefore, we have to use these molecular tests. So it's true. It's about malaria. Okay, 58. Organisms causing filariasis the vector matches correctly. This is kind of by heart thing. Lower Chrysops 5. It's true. Then Wuchereria brancophti, Culex gelidus. It's false. It's not Culex gelidus. Culex gelidus is the one causing JE, I think. Culex gelidus and Tritoneurinthus, it caused JEs. JE. The one who caused filariasis with Wuchereria brancophti is Culex quinquefasciatus. Quinquefasciatus, not gelidus. Then Rugia malai, Mansonia anglifera. It's true. The one we know is mainly like the famous one is Mansonia uniformis, and Mansonia anglifera also can uh, be the vector for Brugia malai. Therefore, it's true. Main one is Mansonia uniformis, but anglifera thari. Then Onchocerca oleolus, black fly. It's true. Then Brugia timori, Culex quinquefasciatus. This is false because Brugia timori is spread by uh, Anopheles species, which like it's not need to remember. එක QLX නෙමෙයි කියලා මතක තියාගන්න. So that's it. This is regarding pilarizes vectors ne? And the other vectors in leishmaniasis and malaria. Then arthropods lecture in those vectors and organisms are frequently asking MCQs. So it's a area like you should buy hard. Even normally matagiti name, so we have to buy hard do stuff. Then 59 pediculosis. Okay, pubic lice are more common to children than adults. So pediculosis caused by three main types of lice, ne? Pubic lice, then body loose, and head loose. These are main three types. Ne? So pubic lice most common in children than adults. Pubic lice mainly seen in pubic hair. Ne? So pubic hair and those stuff mainly seen in adults, not in children. Other than that, pubic lice is sexually transmitted. It also directed towards adults. So this term is false therefore. And Trias pubis is capable of infecting armpits. Trias pubis is the name of pubic lice. So it can infect armpits as well. It's true. Then ivermectin is used in treatment. In pediculosis, we can use ivermectin and permethrin. I think 2% or 5%. Those are the main treatment. Ivermectin or permethrin. It's true. Then non-novicidal treatment must be repeated in 30 days. It's false because this treatment do not destruct over of these organisms. It should be repeated from like around 7 to 10 days, not 30 days. So it's false. Not 30 days, like 7 to 10 days. If it's so, an ovicidal treatment can be repeated in 30 days. But this due to this non-ovicidal, we should repeat after 7 to 10 days. Then infection with body loose may lead to epidemic typhus. It's true. Body loose can act as vector for epidemic typhus. So it's true. Bacterial infection. That's that about pediculosis. Then scabies. Regarding scabies, it is a neglected tropical disease. True. It's a neglected tropical disease. Those not uh, not only scabies like uh, malaria, filariasis, and many other parasite diseases are neglected kind of tropical disease. Then it is caused by obligate ectoparasite. It's true. So, rabies parasite mainly like they make burrows inside the skin. So they are mainly ectoparasites. They don't enter into our body. They mainly stay in skin. Then high disease burden seen in tropical resource poor settings. It's true that meant by this tropical disease thing. Then direct prolonged skin to skin contact with someone with scabies is needed for the disease transmission. It's true. Prolonged skin to skin contact can spread scabies from one person to another person. So it's true. Then when female scabies might burrow through skin and legs, it gives rise to type 4 hypersensitivity reaction. It's true. Because like this hypersensitivity reaction is against these eggs and stools of these mites. So it's true. So as you can see, this erythematous rash is due to this type 4 hypersensitivity reaction. And this is the burrow they made in the skin. And yeah, other than that, this diagnosis part mainly both scabies and spediculosis are clinical diagnosis. But in scabies, we can use microscopic and dermoscopic investigations. Like microscopy means like skin scrapings can be used to identify organisms. And other than that, dermoscopy is kind of special investigation where we use special equipment called dermoscope. This is dermoscope to visualize these organisms in intact skin. So we don't need to take a sample. So we seeing from intact skin. That's that about scabies. Uh, yeah, that's the end of our discussion. So in parasitology now, in MCQs, they mainly we get 4 or 5 MCQs from parasite. Ne. From those MCQs, mainly like in parasitology syllabus, there are three main diseases: malaria, uh, leishmaniasis, and filariasis. Ne. From those three main diseases, two definitely come for the MCQs. Like kanivaring, Other than that, I think arthropods and scabies, pediculosis, and parasites causing those diarrhea, small intestinal and large intestinal nematodes. ඔයනුත් 1 MCQ වගේ. So if you thorough with those main few areas මේ parasite MCQ එක නම් ගහගන්න පුළුවන්. So yeah, that's that. Does anybody have any questions? Okay.
No, Macha.
Okay. Okay. If anyone have questions, like you can put a message or ask from me when you meet me. Okay. Then thank you.